Good afternoon and welcome to our program. As you can see from the overview, we'll have three speakers. I'm Dr. Mark Berger from Actinium. I'll give an overview of our CD33 actinium-labeled program. And then we'll have Dr. Gerald specifically talk about our program in multiple myeloma, and Dr. Van Bezian talk about our program in Myelodysplastic Syndrome, which is actually focused on transplant. So I'll focus on talking about our anti-CD33 program, which is using labeling with radioactive actinium. I'll give you an overview of our program. The program itself is, we often call this ARC, that is antibody radioconjugate program. And what we've done in this program is to use radioactive actinium, that is actinium-225, and used it to label anti-CD33 antibody. In this case, the antibody is called Intuzumab. And as a result, we have a potent alpha emitter because actinium-225, as I'll explain, degrades and puts out alpha particles, which are quite powerful. And so we have a way to use the antibody to deliver the alpha particles. We have a number of different studies in our program. I will talk specifically about our phase 2 trial of older, newly diagnosed AML patients and the results that we recently presented at ASH. We'll also have a number of new programs, an Actimab-A program in multiple myeloma that Dr. Gerald will speak about, a program in MDS that Dr. Van Bezian will speak about, a program very recently announced in combining with a Clagm salvage regimen, which I'll talk about. And then we also have, in addition, a platform to be able to add actinium to multiple antibodies, which I'll speak about, one of the first efforts in that area. So why use actinium-225? There are a number of very good reasons. First, it's very high energy, which leads to very high potency of the molecules that we add actinium-225 to. In the degradation of actinium-225, we have 4 alpha particles that are emitted with a total energy of 5 to 8 mega electron volts, which is a very high amount of energy. As a result, the cells are killed with potentially even with 1 alpha particle, because each alpha particle causes a tremendous amount of DNA double-strand breaks and DNA damage. Importantly, this doesn't need to be internalized, unlike antibody-drug conjugated therapies, which need to be internalized in order to have a certain, to get to a certain concentration of the drug inside a cell. Here, the radioactive material in the actinium can actually push alpha particles. Alpha particles are very powerful, as we'll see, and can go right into a cell. Very short path length. That's one of the really interesting aspects of alpha particles. 50 to 80 microns, which is essentially 4 to 6 cell lengths. So the potential for safety problems is very limited because the actual damage done is done in a very short distance. The half-life of actinium is also perfect for this use. Actinium-225 itself has a half-life of 10 days. The actual biologic half-life of the actinium-labeled antibody in humans is about 3 days as the antibody gets broken down. So this mechanism of action, we believe, is very well suited for radiation-sensitive hematologic tumors. Potentially, alpha particle therapy can be used in patients who are resistant to standard cytotoxic chemotherapy because it can overcome chemotherapy resistance. The mechanism of killing is also importantly independent of genetic abnormalities. So much of the AML treatment today takes patients and reduces them into smaller and smaller categories. But the fact is that the alpha particle therapy can be used regardless of the genetic abnormalities. And of course, there's potential for combining this therapy and this particular mode of action with other therapies such as cytotoxic chemotherapy drugs. We have an expanding CD33 program. Last year, at this time, we'd only have one trial that we could talk about, which is, of course, still ongoing, and I'll give an update. This trial using Actimab-A in newly diagnosed patients with AML over 60 who are ineligible to receive intense chemotherapy due to pulmonary or cardiac or other dysfunctions. And that study is now in phase 2. We also now have ongoing our Actimab-M study, which is a phase 1 study, which looks at patients with refractory multiple myeloma. As we'll talk about, CD33 is actually expressed in a decent quantity of patients with multiple myeloma. Still in the planning stages, but will be happening this year, is our Actimab-Mds trial that Dr. Van Beezen will talk more about. And here we're really using a myeloablative conditioning. We're using higher doses of our anti-CD33 linked to actinium with higher doses to be able to have a bridge to transplant. And finally, we've, in planning stages, or very late planning stages to start very soon, is our study adding actinium to the Clagm salvage chemotherapy regimen. CD33, it turns out, is a viable target in multiple diseases. Expression is really largely in the myeloid and platelet precursors, but actually some later myeloid cells also express CD33. In AML, CD33 is expressed in virtually all patients. In multiple myeloma, much less so. About 35% of patients have some CD33, with about 25% of patients have at least 50% of the cells expressing CD33. And it turns out that this group is a poor prognosis group. In MDS, CD33 is expressed in about 75% of patients, and when it's expressed on a large proportion of the cells. So to give an overview of our AML program, this originally started out actually using bismuth instead of radioactive actinium. And for a couple of reasons, the program then migrated to actinium, which I'll go into. But with the bismuth program, the most important thing was the proof of concept, showing that the vast majority of patients treated had marked decreases in bone marrow blasts. But the problem with bismuth, the main problem was that it had a 46-minute half-life, and that makes it very clumsy to use commercially. And Actimab and actinium, radioactive actinium, as I mentioned, has a 10-day half-life. Gives us plenty of time to be able to conjugate the drug, use it, send it, and make it commercially viable. In addition, bismuth emits only one alpha particle. And as I mentioned, actinium releases 4 alpha particles, makes it dramatically more potent and more effective. So we have some data here from our phase 1 study with radio-labeled, with actinium-labeled anti-CD33 antibody. And here we have multiple decreases in bone marrow blasts as well. And as a matter of fact, we've been able to show in our phase 2 that we have essentially 80 and 90% decreases in bone marrow blasts from the baseline values. So very potent and very effective. In terms of our phase 2 trial, it's a single agent trial, 2 infusions, 7 days apart. And that's used in patients with in older patients who have active AML and who are getting their first treatment for AML. Now, we have a very high remission rate of 69% used as a single agent, which is the data that we presented at ASH and sort of summarized here. In those patients, the median age was 74. 8 of those patients had prior hematologic disease, with 5 having MDS and 2 others having CMML. So these were the standard difficult to treat patients that are seen. Very limited non-hematologic toxicities, greater than grade 3. Clearly the most important toxicity here is myelosuppression, because we're also hitting normal bone marrow cells that express CD33. And that actually is what led to our decision to decrease the dose, actually the dose from 1.5 from 2 to 1.5 microcurie per kilogram per fraction to reduce the myelosuppression, because we found that these older unfit patients didn't tolerate the length of myelosuppression that came along with using the 2 microcurie per kilogram dose. And of course, that trial is now continuing to enroll patients at those doses. We'll have data expected second quarter of this year. We're fairly confident that we can continue to have the efficacy because in the phase 1 trial, when we used, in the group that used 1.5 microcurie per kilogram, we certainly had very high efficacy of 67%. So we're looking to lower the myelosuppression and retain the efficacy, and we'll have follow-up data on that. So we very recently announced this Clagm combination trial. One of the purposes of this, of course, is that the results of treatment for relapsed refractory AML are not great. They need improvement. And one of the rationales here, the main rationale here, is to add a different mechanism of action to cytotoxic chemotherapy drugs. You could continue to add additional cytotoxic chemotherapy drugs and continue to have toxicities that build on each other. But this way we come in with a different mode of action with a toxicity that really only has a little bit of myelosuppression, and we think we can really improve response rates. So we have a phase 1 trial that's ongoing, that'll be ongoing in adult relapsed refractory AML. This allows us to treat younger patients as well as our, to add that, since our present trial is in unfit patients, is in older adults. We'll have 12 to 18 patients to determine the MTD, and the study will be done at Medical College of Wisconsin, where Dr. Atala and Dr. Abedin have been organizing this trial. So it allows us to expand and find another use for Actimab in a way that we think can add relatively little toxicity to a salvage regimen. And finally, this is our first, one of the first efforts of our platform. And the platform is to add actinium, radiolabeled actinium, to other antibodies. The antibody here we've picked is daratumumab, anti-CD38 antibody used in multiple myeloma. And these are some initial data from 3 different cell lines and several different times, 24, 48, and 72 hours, showing that if you add actinium to daratumumab, you get between 50 and 80, 90% more cell killing. You get dramatically more cell killing by adding the radioactive actinium. And of course, this is what you'd expect because you're now not adding to the anti-CD38 activity, but you're using the alpha particle therapy as well to have multiple DNA breaks and kill cells as well. And obviously, this is some initial experiments in cells, and then we'll be moving this forward. So it's a platform that we can use in many different ways, and we're excited about being able to do that.
What I think is actually, a launching pad for a new way of making high-dose melphalan better. So as many of you know, the field of autologous transplant has actually based itself on this dose-response curve. And it was actually based on the dose-response curve with lethal radiation that was discovered or seen after the prolonged aplasia that was seen in the victims of Hiroshima and Nagasaki. So the pioneers in our field thought, well, if you could give radiations at higher doses and rescue patients from lethal bone marrow, you can expand this dose intensity effect in patients with different hematologic malignancies that reside in the bone marrow. The same holds true for alkylator therapy. So in alkylator therapies, melphalan busulfan, the main initial dose-limiting toxicity is lethal bone marrow toxicity. And if you can rescue that either with growth factors or bone marrow support, you can then exploit a dose response that exists or was initially demonstrated by Tim McElwain for melphalan now more than 20 years ago. Unfortunately, the first initial experience that Tim McElwain and Ray Powles did in myeloma actually showed that you could get a dose response curve, but there was severe neutropenias and severe myelosuppressions that led to myelosuppressive deaths. And it was then Bart Barloghy who showed that you could rescue those patients with bone marrow And literally, one of the interesting things, that even if you gave bone marrow that was morphologically contaminated with plasma cells, the bone marrow would be effective enough in rescuing patients from high-dose chemoradiotherapy. I'm going to, fast forward to now. It's been more than 25 years and multiple randomized trials showing that high-dose melphalan remains, the single most effective way of achieving a complete remission, and it remains a standard element of the initial care of transplant-eligible patients. This was the latest randomized trial looking at an early versus late transplant, and as you can see, there's a significant benefit in progression-free survival for all patients. That actually not only was it significantly, it was very clinically meaningful, with the median progression-free survival not having been reached in patients who got high-dose melphalan consolidation versus 44 months for patients who were receiving continuous chemotherapy. For the first time in modern times, there has also been a survival benefit, particularly seen in patients with high-risk disease, either as characterized by abnormalities of 414 or 1416, deletion 17 or deletion 17 or deletion 17 positivity, or ISS grade 3. So this is not only a progression-free survival benefit, but in people with high-risk disease, the use of high-dose melphalan with autologous transplant support resulted in a significant survival benefit that you can see there. So as we think about will high-dose melphalan be replaced with all these new drugs, and the conversation that happens every 1 or 2 ASHs, I think as of now we can consider that high-dose melphalan remains an important element for long-term disease control in myeloma patients. So, as questions as to how can we go beyond high-dose melphalan, I remind everybody that high-dose melphalan has been compared to melphalan and total body radiation in a randomized trial, and melphalan 200 remained more effective than total and less toxic than total body radiation. The French have recently concluded a randomized trial of melphalan in combination with bortezomib that did not result in improvements in overall survival or progression-free survival. So improving the conditioning regimen has been a challenge, and melphalan 200 milligram per meter squared remained the standard of care. So one of the ways that we've been thinking about trying to improve high-dose melphalan is actually the same way we do busulfan-targeted therapy, in that we've shown that busulfan-targeted therapy does improve outcomes, because when you just give a flat dose of busulfan, about 30% of your patients are probably going to get too high a dose, 30% of your patients are going to get too low a dose, and only 30% of your patients will actually be in the sweet spot. Those who get too low of dose will probably relapse. Those who get too high a dose will get higher toxicities. Traditional melphalan has been difficult to do PK-directed therapy because it's very unstable and hydrolyzes very quickly. So it is a challenge to be able to do PKs, because you have to have literally a runner who's running with the samples to the mass spec so that the samples gets done in real time. Propylene glycol melphalan, which is known commercially as Ivomela, is actually much more stable. And now it allows us to do PK-directed dosing without having to have the Chasqui runnings back and forth from the bedside to the PK lab. So Gunjan Shah from our institution just did a initial pilot study saying, could we actually do PKs at real time, and can we do PK-directed therapy? This is just to show you that there seems to be a sweet spot, that there is a population distributions of melphalan pharmacokinetics among 22 patients that we tested, and that patients who get an AUC of above 12.35, and the benefit comes to the Australians, the group of Dr. Nath, who were the first to show that there probably was a sweet spot for melphalan, and that the melphalan PKs had a population distribution. And the patients who got a higher dose of melphalan had higher mucositis, but they also had a better disease control. Again, suggesting that there is a sweet spot for melphalan that we need to target. I'll advance with you that we actually tried to do dose targeting with a small test dose of melphalan at 10 milligram per meter squared, but we were unable to get good enough PK curves. We're now doing a pilot trial where melphalan is divided into 100 milligram per meter squared, and the first dose is done to give the PK that will then give us a formula that will allow us to dose adjust the second dose of melphalan to try to get as many people around the 13 micrograms that we think is the optimal dose is where we're targeting patients at this time. We don't know if it's the optimal, that's just the one we want to target. Amifostine in a non-randomized trial. This was a comparison between the Case Western case series, in which everybody who gets Melphalan 200 gets amifostine, versus the MD Anderson series, where patients do not get amifostine generally. They only get cryotherapy with ice. Seeing if the addition of amifostine could reduce gastrointestinal toxicity and make high-dose Melphalan easier. Again, as a retrospective analysis, it did show that there may be a benefit for amifostine in reducing all GI toxicities, particularly diarrhea, vomiting, mucositis, and nausea. It is unlikely that they will see this as a randomized trial. Amifostine is not an easy drug to give. You have to give it frequently. But again, it just shows that there are strategies that will allow us to improve not only the safety, the tolerability, and maybe the efficacy of Melphalan. And finally, again presented at ASH last year, was a randomized trial performed at MD Anderson by our colleague Musafir Kasselbash, comparing busulfan Melphalan to Melphalan, and again showing a significant benefit for the more intense regimen of busulfan Melphalan versus Melphalan alone. Until recently, retrospective analysis comparing busulfan Melphalan versus Melphalan had failed to show a benefit for the busulfan Melphalan combination, partly because busulfan was not being dose adjusted. So where does targeted radiotherapy come in as part of the conditioning regimen? So we all know that increasing radiation dose does reduce the risk of relapse in myeloid leukemias. And the idea in myeloma was that maybe if we could target radiation, in which myeloma is a very radiosensitive disease, we would be able to deliver high doses of radiation to exactly where the tumor is and be able to improve the responses. So back when I was at MD Anderson together with Dick Champlin, we explored the use of holmium DOTMP as a way of improving transplant outcomes for myeloma. DOTMP is a chelating agent. When put together with the holmium radioisotope, actually becomes a bone-seeking radioisotope, as you can see there, and allows us to deliver very high doses of radiation straight to the bone marrow through that targeting to rapidly turning over bone. We actually, holmium is a high-energy beta emitter as opposed to actinium, which is an alpha emitter. DOTMP is a tetraphosphonate that it, localizes to areas of increased bone turnover, which you would expect with myeloma. So, we had initially started this as a phase 1 at low doses, and we had a very good response rate, so 46% CRs among evaluable patients responsive to induction therapy, and 23% CRs evaluable patients with primary refractory patients. These were the highest rates of CR we had ever seen. Unfortunately, as we got to the higher doses, we started seeing thrombotic microangiopathy, which is essentially undistinguishable from radiation nephritis, which is what probably it was. And this was probably because our expectation was that as holmium DOTMP gets circulated through the kidneys, it was radiation in the kidney microvascular. And as opposed to what we expected the kidney was able to tolerate as external radiation therapy, when it was given as an internal base, this was not well tolerated at the higher doses, and no further development of the compound was done. So where have we explored radioimmunotherapy? Tosutumumab, again, is a radioimmunoconjugate against CD20. Again, here it was not successful, randomized trial in patients with non-Hodgkin's lymphoma comparing Rituxan beam versus Tosutumumab beam did not show a benefit. And we're uncertain why was that the case. And partly is because non-Hodgkin's lymphoma probably resides in different places where the antibody might not get to adequately. So what about Actimab? And so as the group of actinium came to us and were discussed, well, is there a role for this compound in multiple myeloma? As you just heard from Mark, there is a 30% of the patients who actually express CD33 on their plasma cells. So we think that this is a way of selectively delivering radiotherapy, and there's all the advantages that you just heard of. Actinium is a potent alpha emitter. We have experience using it in myeloid leukemias. So we think that this is not only is it a good platform, but as you heard, we think this is, again, what we're going to learn with the study with CD33 radioimmunoconjugate will allow us to then to a CD38 or a BCMA radioimmunoconjugate, which probably will then expand the indication not only to CD33 positive myeloma, but to CD33 negative myeloma. So is CD33 expressed in myeloma cells? The answer is yes. Approximately, a third of the patients have some level of CD33 expression. Interestingly enough, CD33 positive patients have a worse outcome than CD33 negative patients, as done in this retrospective analysis. So there is not only is it expressed in the plasma cells, it's expressed in plasma cells that have worse behavior. So, our idea here is that in patients who have failed primary therapy, second transplants are a valid indication. They have shown to improve outcomes, particularly in a randomized trial from Gordon Cook from the UK. So the idea is to treat patients who have failed primary therapy with a dose of Actimab CD33 radioimmunoconjugate with the hope of getting a deep remission and long-term disease control. So we do think this is, again, is a proof of concept. I remind the group of patients that are treating are a group of patients who have failed first and second line treatment. Their expected progression-free survival is usually 12 to 18 months. So anything that we can get in that range would be considered positive for further development. Should we be looking at, what level of expression is positive or negative? I was just speaking to Mark. As we're putting the trial through, we're thinking any level of expression will be considered as positive. The antibody has a very high affinity to the CD33 antigen, and again, all you need is one particle. So at this time, we're going to be agnostic to the level of expression, and any type of expression on a plasma cell will be considered positive and will allow patients to go on study. And this is just the COMPASS data on the percent of CD33 expressing cells on 865 patients whom sample was available for, of which 25 expressed some form of CD33. So this is the study design. We're going to explore 4 cohorts of patients, increasing the activity from 0.25 microcuries per kilogram to 1.5 microcuries per kilogram. Initially, at the initial dose, we are not expecting myelosuppression, but if we get that, then patients will be getting filgrastim until the ANC count's greater than 1,000. At least for the first, when we get to the higher cohort of patients, we are expecting to have that these will be patients who will have stem cells in the freezer in case we get, very prolonged myelosuppression, that we can rescue these patients. Spironolactone is given just, remind me what, we'll go over why spironolactone is given afterwards for a year. And you explained this to me, but I forgot now. I'm having my aspirin moment. The idea, again, is if that patients tolerate the first cycle well and they've responded, you're allowed to give a second cycle. So remember, this is not a transplant study. These doses are not expected to be myeloablative. They're expected to be myelosuppressive at the higher dose. Because patients have been extensively pretreated, once we get to the higher dose, we may have to put a safety caveat that patients have to have stem cells in the freezer. Most myeloma patients have enough cells for 2 transplants. So we think that this is really a unique opportunity. Multiple myeloma is highly radiosensitive, but up to now, we have not been able to exploit that radiosensitivity. External beam radiation with total body radiation has been associated with significant toxicities and not shown to be beneficial. Targeted radioimmunotherapy using holmium DOTMP, although showing efficacy, was not well tolerated because of renal toxicity. We think that there are unique characteristics of Actimab-A that can be used in combinations not only as a single agent, but in combination with other cytotoxic agents. The idea is eventually combine it with high-dose melphalan prior to an autologous transplant. The mechanisms of actions are different, and as opposed to homeodotMP, we think the safety profile will actually also be different, and there's now extensive experience with more than 100 patients treated showing that at least there is no nephrotoxicity signal that has been seen today. So in summary, relapse is the most important cause of treatment failure after transplant. Risk factors for relapse have been well characterized, but no definitive strategy has been developed that will reduce the risk of recurrence without increasing other complications. We think that, that radioimmunoconjugates such as Actinium-A can both as single agents be useful for patients with multiply relapsed disease and more importantly, in combination with other agents, can be used as an effective platform for conditioning regimens after transplant, that it will allow for deeper responses and better disease control in the context of a high-dose melphalan backbone. And as I've said many times, I think our traditional triple P transplant, where we're pushing the drugs, we're pouring the cells, and we're praying that it all works out, has to be abandoned, and that we need to move the field forward by looking at these agents that have novel mechanism of actions and that can be combined safely with our current backbone. Thank you very much. So if there's no questions, it's my pleasure to introduce my friend and colleague, Dr. Koen van Bessien from Weill Cornell Medical College, who'll talk to us about the use of this drug as a bridge to transplant.
Former neighbors as far as offices and now current neighbors across the street. I will talk to you briefly about a trial that is close to being opened on using Actimab as a bridge to transplant for patients with p53 positive myelodysplastic syndrome. Why p53 positive myelodysplastic syndrome? It seems quite obvious. It's a very unmet need, and I'll show you some data to support that. So I'm on one side of the street, and surgery is on the other side of the street. Myelodysplastic syndrome, as you all know, a disease of the elderly, a common disease, more than 100,000 cases according to this estimate here. A disease with a variable prognosis. Some patients are quite indolent, but many are quite aggressive and ultimately die of the disease. The only curative option is an allogeneic transplantation, and as many of us know, it is far from satisfactory. We categorize these patients by the International Prognostic Scoring System. I'm not telling you anything new here, based on cytogenetics, bone marrow blasts, hemoglobin, platelets, ANC. We assign scores to each of these markers, and a score of greater than 6 is very high, a score of 1.5 to 3 is low, but even low is pretty bad in my opinion. Half of these patients have died within 5 years. I believe these scores tend to be underestimated, and it could be argued that most of the patients are in need for better treatments. What are these treatments then? The treatments can be supportive care, not very gratifying if you're in one of these categories. Even when you're 60, many of us are getting close to that or over that, and it sounds awfully young these days. And one can use hypomethylating agents, which have been used now for the last decade and a half. Can induce remissions, can prolong survival somewhat, but are far from curative. One can also use, obviously, more intensive leukemia-type treatments, but they are more toxic, poorly tolerated by the older. One can use stem cell transplant, but it has its own problems. Stem cell transplant can be given in very high doses, what we like to call myeloablative conditioning, and then are poorly tolerated, or can be used in reduced doses, because about 20 years ago we figured out that we could get away with that. We could give fludarabine, and we could get cells to engraft. There was a wave of enthusiasm, and there continues to be, but we've also learned that the reduced intensity conditioning regimens have high relapse rates and have their own problems. We categorize further the patients based on their age, somewhat, although we like to go away from that, and we like to talk more and more about their fitness versus their frailty, and fitness versus frailty as defined by a number of comorbidities, but also by the way people live. There's plenty of patients now with many comorbidities, have had heart surgery, have had prostate cancer, and are living very healthy lives and coming skiing here in Utah. So fitness is more than comorbidities. Fitness is also it's a mental issue. It's an issue of being active, and we are learning a lot about these. And my former colleague at the University of Chicago, Andy Arts, has done a lot of work in that field, and there's others who do this. There's also, as I treat more and more older people, there's also a mental fitness, and we are learning or only scratching the surface. But what I want to talk about a little bit is the mutations that now are becoming important. And this trial, the trial that I will discuss here, is built a lot around the concept of the prognostic value of mutations. We have known for years that cytogenetics matter. And cytogenetics, after all, are a way of detecting molecular mutations under the microscope. And some very giants in the field, Janet Rowley among others, have really opened up this field and have made us aware of the importance of this. And it's fitting, since we talk about melphalan, which is a 60-year-old drug, that we are still discovering novelties about, that we pay tribute to all these people that really opened up the field. And cytogenetics opened this up, and now we have molecular tests, and we do mutation analysis. And many of you, this is just a slide to tell us that we are doing more and more transplants. That's in part for Myelodysplastic Syndrome, and that's in part because older people are fitter. Older people, there are important reductions in toxicity thanks to supportive care. But and there's more interest in transplant, but the results are not always good. When talking about mutation, somebody was asking here, P53, what does it mean? And P53 is a tumor suppression gene, cannot pronounce that, that is present in about 20% of patients with MDS. There's other genes, and I cannot read it from here, but they are now well in our other mutations. We are all familiar with them now. ASXL1, NMDP, TET2, RUNX1, either mutations in transcription factors or mutations in epigenetic modifiers. But I will try to convince you that P53 is one of the more important ones. And looking at the top part of this curve, this is from an abstract presented by a consortium of 6 institutions and presented by my colleague Sang-Min Lee from Cornell. They looked in 963 newly diagnosed MDS patients at the prognostic relevance of 6 of the most common molecular mutations, including the ones I mentioned, ASXL1, DNMT3, TET2, P53, and I forget what the 2 last ones were. They found that actually, for prognostic purposes, by far the most important one was P53. It was a very, very adverse prognostic factor, and patients with a P53 mutation had 2.5 times worse survival than all the other ones. That did not apply to the same degree to any of the other common mutations. Why does it talk here about moderate impact or high impact? I actually had some trouble figuring that out myself. I had to read the abstract again. But one now looks at subsets of mutations, and there's prediction algorithms for how important a mutation is going to be and how much a particular mutation in P53 will affect its activity. Turns out that most of the mutations in P53 were considered moderate by these prediction algorithms. About 2% were considered to have a high impact. In reality, it didn't matter whether they were of moderate impact or of high impact as predicted. They both had equally poor overall survival and equally strong adverse prognostic prediction value. That is with the newly diagnosed patient with MDS. Why don't we transplant them all? And what happens if we transplant them? This is from a paper in the New England about a year ago now, where they did the same thing, predicting outcome of patients undergoing allogeneic unrelated donor transplant, if I remember correctly. and try to define molecular and cytogenetic predictors of outcome. And they found again that despite transplant, p53 mutations were extremely adverse factors. And we know that now. We've learned that in the last 3 or 4 years since we routinely do these mutation analyses. When we get a p53 mutation patients, we are exceedingly worried. And I think all of us here who are transplanters have learned to deal with the adverse impact. So a major unmet need, how to do transplants. I should add to this, the major reason why these people fail is not so much transplant-related toxicity, but it is disease progression. So this consortium of 6 institutions, Cornell, Cleveland Clinic, Hopkins, Moffitt, Dana-Farber, and MD Anderson, consortium studying MDS has proposed this trial in collaboration with Actimab. And Gail Robos, my colleague, was supposed to give this talk, but she's traveling somewhere in the world, so I'm giving this talk for her. And the rationale is that CD33, as expressed in 75% of the MDS patients, we hope that we can add Actimab to the conditioning regimen. You've heard already that the drug has very limited extramedullary toxicity, is overall well tolerated, and we focus on the subgroup of patients with p53 mutation. So the rationale then again is that we don't want to do myeloablative conditioning. Patients are older, patients will not tolerate the extramedullary toxicities. We don't want to use regular reduced intensity conditioning because there's too much relapse. So we combine Actimab with a reduced intensity conditioning, and we hope that we will avoid the extramedullary toxicities of the myeloablative conditioning, that we will have a very targeted anti-MDS effect, and that ultimately we will obtain improved survival. This is the trial, and you've seen a similar slide from Sergio. The biggest difference here is that the dose of actinium. We give a dose of actinium here that is twice of what has been given in other trials. We administered this dose, and then about a week later, we come in with our reduced intensity conditioning, followed by an allogeneic, either related or unrelated donor transplant. The trial is supposed to have 60 patients. We believe that's easily feasible with those 6 institutions participating. And the efficacy endpoint is going to be the survival at 1 or 2 years after transplant. So details of the trial, it's going to be a phase 2 trial, open label. As mentioned before, it should have about 60 patients. Prior treatment is allowed with hypomethylating agents, diagnosis of MDS. There's a requirement for having greater than 25% cells that are CD33 positive, which is the majority of patients with MDS. Patients have to be 18 and above. I expect that they will mostly be in their 60s and 70s, and they have to have a TP53 mutation. And that's it. With that, thank you. If you have any questions, I'll be happy to answer them.
In regards to, is there any risk of engraftment to the graft, engraftment with actinium being given or Actimab being given, and then 10 days later you're doing the allo transplant?
You're asking a good question. You want to answer that?
Yeah,
Mike?
sure. So the answer is no, not the way that we'll do it. We've done the same kind of preparatory work with the Aml program, a different program that we have. And basically what we've done is look very carefully at the time that it takes for the radiation that's available in the body to come down to levels that can't cause any harm to the graft. So we've done exactly the same thing in preparing for this trial, is take the PK data we have and basically make sure that the time that we give, and basically 14 days later, is the sort of short answer to your question. You don't have to worry about that because there's no more radioactivity. But certainly you can't give the cells immediately after giving a radioactive material that's aimed at myeloid cells. Exactly right. But it's quite manageable.
Yeah. So I said it's probably wrong saying 7 days. I said it's
In,
more
in,
going
in,
to
in this
be,
case, it's 14, because
14
we've
days,
done the
yeah.
work.
Yep.
In terms of the spironolactone that was mentioned in the last set of slides, I was wondering if that could be addressed at this point.
Spironolactone.
Yeah,
What's
so
the rationale?
it's an interesting question because it turns out that the radioactive bismuth potentially can accumulate in renal cells, and in the original animal experiments done, where actually the animal did not have CD33 that was recognized by the antibody persisted for much longer, and bismuth did end up in some cells in the renal cortex, and there was some renal toxicity. So basically, in experiments to look at that, they originally started off with diuretics using Lasix, and ended up using spironolactone as an alternative and seemed to find some benefit for spironolactone. The actual mechanism isn't really understood, and whether it's anything more than just simple diuresis. And also, I have to note that we haven't seen any renal toxicity in our actinium program in patients to date. And so whether this is related to the fact that the animals didn't have CD33 recognized by the antibody, and so there was great persistence of this material, is still a little bit unclear. But we're not seeing that clinically. Nevertheless, we decided to put in spironolactone and use it just as a preemptive measure.
So the NRC, Nuclear Regulatory Commission, as you know, regulates this kind of thing. I just wonder what exposed patient, what precautions, if any, are required by the NRC with regard to body fluids, nursing personnel, rooms, et cetera, et cetera?
So clearly we pay a lot of attention to that. One of the wonderful things about alpha particle therapy with actinium is that alpha particles are stopped by a piece of paper. They're stopped by your skin. So there's no radiation being emitted by people who receive this therapy. And therefore, they can get the therapy as an outpatient, and they can go to the mall, wherever they want to go. However, your point is well taken. There do need to be proper nursing procedures to make sure that nurses administering or people administering aren't in contact with bodily fluids from the patient, because they actually can potentially contain some radioactive material, particularly early on. But otherwise, there's nothing special that needs to be done, for instance, when the patient goes home. And that is one of the real benefits of using an alpha particle therapy.
And that's true in every state. There's no local regulations that affect this?
Well, actually, many of the regulations are state by state. Some states don't have their own regulations, use national regulations. But the answer is yes. And none of this is related to regulation.
I have a somewhat tangential question. In this low CD33 expressing disorders, is there any work on inducing CD33 expression in either plasma cells or?
That's a very interesting question. The only work that I know of is that it turns out that apparently there's some effect from anti-CD45 antibodies that can raise somewhat CD33 levels. It's a potential avenue for the future, but we're not aware of other ways to do so, but it certainly is one way to potentially make this treatment more viable to a larger multiple myeloma population.
Mark, can you speak as to why Clagm has been chosen for the AML study?
It's basically investigator-initiated. I mean, I think there's certainly potential to use actinium and actinium-labeled antibodies with other salvage chemotherapy regimens. So no, it was really convenience as much as anything else. In other words, there's no reason not to use it with other regimens.
Mark, if we could also give credit to the Baylor people who started the CD33 program in myeloma.
Yes, actually, that's actually where the multiple myeloma study started, and much of the it was started as an investigator-initiated trial there, and actually we've now brought it in-house because we wanted to expand the number of sites and move the trial faster. But I think that's exactly right. There was a number of different ideas that have come to us from others. the Clagm idea, the multiple myeloma idea, and frankly, the MDS idea from Dr. Robosa as well. These are ideas that people have looked at this with us and said, well, how can we take advantage of the actual strengths of this drug, and where can we use it?